Thank you for the opportunity to present our work. I have no relevant disclosures, but we would like to thank the North Carolina Department of Health and Human Services for their collaboration on our project. A new childhood cancer diagnosis is accompanied by significant emotional and financial strain. And in addition to these devastating diagnoses, families are often challenged by significant logistic burden as they try to navigate complex treatment regimens. And pursuing that care is hard. It requires families to partner with their communities, pursue transportation, housing, and additional childcare as they navigate these very complex oncologic therapies. And a lot of families actually require additional financial support as they go through these treatment regimens. And so with all this in mind, we sought to examine a financially vulnerable population of patients through North Carolina DHHS, our collaborators. We identified a group of patients with a new diagnosis of renal malignancy. We selected renal malignancy because the ICD code for that particular tumor very well correlates with patients who are being treated for Wilms tumor. A little bit of background on Medicaid. Medicaid covers 45% of children nationally. It's an income-based payer, and in most states that requirement is 210% of the federal poverty line or lower. They serve as the primary medical payer and pharmaceutical payer for these patients. And there are some additional services that are offered on a state-based level. In North Carolina, one of those particular benefits is the assistance in non-emergency medical transportation for appointments. Our cohort of North Carolina Medicaid patients consisted of children who were age 21 or younger, had a new diagnosis of renal malignancy, a subsequent nephrectomy, and at least 30 days of enrollment before and after their renal malignancy diagnosis. The outcomes that we were interested in were inpatient and outpatient healthcare utilization, the amount that was billed by providers and the amount that is reimbursed to providers, and finally, a composite metric which is called days medicalized. This is the total unique days between inpatient days and outpatient days, and it's a good reflection of the actual logistic burden that families are going through as they're pursuing their cancer care. These are the demographics for our population in our study. We had 87 patients. Their median age was 3 years old. Our patients were predominantly white, and most had a private living arrangement. In assessing our goal of whether we were finding a financially vulnerable population, this is the interquartile range of our patients' monthly incomes, which was $0. So 75% of our patients in this study had a $0 monthly income at the time of their renal malignancy diagnosis. These are some very basic healthcare utilizations. You can see here that the majority of our patients required a single admission, had a single surgical intervention, had a very small number of procedures. One thing that we did find interesting was that there were a lot more imaging studies than we predicted. When we looked at that, that primarily consisted of preoperative imaging, post-procedural imaging, and then renal ultrasounds at follow-up examinations. Looking at our outpatient experience for these patients, the vast majority of this occurred in the first 6 months of their treatment. However, at the 1-year mark, the median number of outpatient encounters was 26. You can see here that 25% of our patients spent 36 or more encounters in the outpatient setting. Similarly, our inpatient care was primarily in that first 6 months of treatment. However, you'll see at 1 year that we did have 25% of our patients who spent 37 or more days as inpatients. And finally, when we looked at the medicalized days, so that composite metric of how many days patients were actually seeking medical care, the median number was 50 days at 1 year. And you'll notice that 25% of our patients, again, that upper part of that interquartile, spent more than 3 months pursuing their cancer care in that first year of treatment. I'm not a big money guy, but just because we did look at billing data, I'll share this with you. One thing that we found very interesting was that when we looked at the number of medicalized days, there was almost a direct ratio of $1,000 per medicalized day in what was reimbursed to providers. And all this kind of speaks to the phenomenon of financial toxicity. And if you're not familiar with that, that's something that's well described in the adult literature as the effect of financial stress during cancer treatment having a result of a worse treatment outcome. And that typically comes in direct costs and indirect costs. Direct costs, I think, are the things that are easy for us to comprehend in our day-to-day jobs. So how much it costs to go to the doctor, how much your prescriptions cost, how much your hospitalizations cost. What our analysis really adds to this is this demonstration of the number of days that patients are pursuing care. And in this study, that median was 50 days. So that means that there were 50 days where patients were driving back and forth to the hospital, paying for parking, 50 days where they were thinking about housing or additional childcare, 50 days where they were buying food from cafeterias instead of their grocery stores, and 50 days where their income was disrupted. What all of that does is it affects our medical decision making. And that, in the adult literature, especially in breast and colon cancer, has led to worse treatment outcomes. So in conclusion, we're able to demonstrate that there's a significant number of medicalized days for patients pursuing care for renal malignancy, but most likely Wilms tumor. And even though in North Carolina we do fund kids up to 210% of the federal poverty limit, we do still have a number of kids who are uninsured, and these stressors would be even more elevated in that population. We think that moving forward, as we're looking at cancer treatment regimens, finding a way to look at the logistic burden on families is important, and medicalized days can be an important way to do that. Thank you for listening to a policy talk, and I'd be happy to take any questions.
As Dr. Hayes is coming up to the podium, I have a quick question for you. Did you, this is a really wonderful way of understanding the burden of care. It's really, really important. I was just wondering if you looked at racial or ethnic disparities between that at all?
Yeah, so we did look at racial and ethnic disparities. The primary racial groups that you saw on our demographic slide were Caucasian, African American. We didn't notice any significant disparities in the number of days that they were medicalized.
And did you compare it all to insured, like an insured patient group?
We didn't have any access to any insured data. We only had the Medicaid data. Yep. Dr. Hayes, Jordan?
Yes, Andrea Hayes, Washington, D.C. Thank you for that nice presentation. A question and a comment. One is, in the adult literature, the financial toxicity in cancer patients is mostly focused on the young adult group that are either in school or don't have jobs, et cetera.
Yeah.
Did you happen to look at a similar correlation in the kids as far as age? Because I imagine if the children are more infants and not yet in school, that may or may not impact their perception and their financial toxicity.
Yeah, so unfortunately, we didn't break it down by age that way. One of the assumptions that we had in this study, though, is that most of these families are going to be younger. It's going to be parents supporting children as medical decision makers, and that their acquired wealth as they're undergoing their child's cancer treatment is going to be significantly lower than what we would actually see in breast cancer patients and colon cancer patients who have been able to work for a few more years before that cancer diagnosis.
The other comment I want to make as far as resources that you may be aware of, but maybe others in the audience are not, is through the Social Security Administration, some parents I find are not aware that they have the opportunity to get resources up through 2 years after their child's cancer diagnosis. And so I find that I'm sometimes the first person to mention that to the families, so that patients with $0 income or who are on welfare can always get monetary support during that time frame. So just a comment for people.
Yeah, I definitely appreciate it. And one thing that we've been doing is trying to find a way to integrate financial navigators into our clinics as well, because they can help to set up connections with programs like that.
Yeah, Phil Frickman, Los Angeles. I think it was a very nice talk about the financial burden of cancer care. One of the questions I had was on the data on one of your early slides where you looked at the income of the patients, which was 0. Of course, that would be expected because they're age 3 on average, correct?
That's their parents' income, sir, not their personal income.
Well, I understand that, but I mean, you're saying every patient in your study had an income of 0?
No, so the interquartile range included patients through the 75th percentile who had incomes of 0 for their families. The sort of top deciles of that, I think it was about 93rd percentile and up, we started to see appreciable income. The highest income in the study was about $2,300 a month.
Okay, thank you.
Yep.
Tim Lotz from Chicago, great presentation. I just have a quick comment, which is to say that this data can help us to try to help our patients, right? Because we often get asked to do things that might not always be the most convenient for us, but can help the families sort of lessen this burden. And whether that's seeing a post-op nephrectomy patient when they're coming in already to see oncology for chemotherapy, or coordinating a port removal with something else that they're coming in for, I think we can use this data to change how we practice to better help our patients with this.
Thank you.
Thank you very much.
Thank you.